Rubella, then we'll do the case, and then we'll jump into the next set of viruses, which off the top of my head, retroviruses. I was like, I literally just put them up, so I should know what they are. They are retroviruses. Okay, so rubella is an alpha virus, just like the arboviruses. However, rubella is not transmitted by arthropods. It is not an arthropod-borne virus, even though it belongs to a family of a lot of arboviruses. It is just like the alpha and flaviviruses, single-stranded RNA virus. It's a positive sense strand virus, and it is enveloped. It's transmitted via respiratory droplets, and it doesn't really cause a lot of CPE. So a lot of the effects that we see from rubella are because of the immune response, not because of direct tissue damage. Sometimes they call it German measles. It does sometimes look a little bit similar to measles, but not as severe. But where we worry about it is if a woman is infected during pregnancy. So in an otherwise healthy adult, rubella, not that big of a deal. Even in a child, not that big of a deal. During pregnancy, it can cause significant defects to the fetus, cataracts, so it can cause blindness, deafness, other congenital defects, miscarriage, stillbirth, all of those things. So again, respiratory virus, but it can cause a rash, and so what you see is it gets in the body, and in the respiratory tract, where it can replicate, it can then cause a primary viremia and get to places like lymph nodes and liver and spleen, and cause a rash, and it can also get then into the placenta and into the fetus and cause a congenital infection. So what you would typically see with rubella is anywhere from like a 7 to 10 day period between incubation and the onset of the rash and fever. Rash and fever will usually show up right around the same time. You may have patients with some swollen lymph nodes, but they don't yet have like the rash or the fever. And then again, in most patients, this will go away. Not generally a problem. It's only when it gets to the fetus that we have a really big issue. So humans are the only known host for rubella, so it has to be a person-to-person transmission. And one of the issues is that people will spread the virus. So if we go back to this previous slide, you have a really high load of virus in the pharynx, so in the upper respiratory tract, even before symptoms start. So people can be shedding virus in their respiratory secretions before they develop symptoms, so they wouldn't know that they needed to isolate. Because of how dangerous this virus is during pregnancy, many states routinely test for anti-rubella antibodies during pregnancy. Now, rubella is the R of MMR, so measles, mumps, and rubella. Of course, the assumption is that if a patient has been vaccinated, they should have antibodies. But sometimes, even if they've been vaccinated, the antibodies can wane. Maybe the memory response wasn't as good as we want it to be. And so that's actually what happened to me. I got screened for anti-rubella antibodies and I didn't have any. So I had to get another MMR booster. And I know my first MMR shots when I was a kid worked because when I worked for the Army, I had to get screened for anti-measles antibodies, and I had plenty. But for whatever reason, my memory response to rubella wasn't detectable. So I had to get the shot again. And that's fine, it protects the fetus, and it wasn't really that big of a deal. After, again, that kind of 10 to 14 day incubation, sometimes up to 3 weeks, patients will have rash and swollen glands. In adults that have a robust immune system, the symptoms might be a little bit more severe because adults have a stronger immune response. remember, this virus isn't really causing CPE. We're not seeing those cytopathic effects. Instead, a lot of the symptoms we're seeing, so fever, right? That's a general immune response to infection. Rash is often a T cell response killing infected cells. So that's why adults might have more severe symptoms, because they have a more robust immune response, that immunopathogenesis. So there was an outbreak of rubella in the mid-1960s. And so it shows you the numbers here. There were an estimated 12.5 million cases in the US. This was only in the US. 12.5 million cases. About 160 people reported like joint pain, muscle pain, just joint pain, arthritis. About 2,000 people developed encephalitis. That's not bad. Deaths. So excess neonatal deaths. 2,100. So what that means, like when you're doing epidemiology and you're trying to figure out these kinds of numbers, what you're looking at with something that's called excess neonatal deaths is you're looking at what is the normal baseline of neonatal death, which is kind of a morbid, horrible thing to think about, but there is a number of how many people have a miscarriage or stillbirth every year. So how many extra neonates died? So 2,100. Other deaths, 60. So that's not, again, not very much. Excess fetal wastage, which is a really, really horrible way to say it, but the other term would be like a spontaneous abortion. So it's really early in pregnancy. The person probably knows that they're pregnant, but the fetus was not of an age where they would have survived outside the womb. So that's kind of the distinction between like a miscarriage and a stillbirth. If the child would have, or theoretically could have, survived outside the womb, then that's a stillbirth. If it's prior to that, it's a miscarriage. They usually use 20 weeks as the cutoff. So prior to 20 weeks, a miscarriage. After 20 weeks, a stillbirth. And then a neonate is an infant. So that's a lot. And then congenital rubella syndrome. So these were children that were born. 8,000 children were deaf. 3,600 deaf and blind. Mentally retarded. I know, it's like these textbooks use these terms, but from the 1960s, that's the term. So cognitive defects. 1,800 other symptoms, about 6,600 total, like living children that had some sort of rubella symptom at birth, about 20,000, and 5,000 therapeutic abortions. So the mothers knew that there was going to be a significant defect with their children and chose abortion, so therapeutic abortion. Okay, so that's why we worry about it in pregnancy. 60 out of 12 million people dying is not something we typically worry about, but 20,000 children that are born deaf, blind and deaf, maybe limited eyesight, cognitive defects, that's what we worry about.
So mom had the virus, that's how she got the virus?
Yes, mom was infected during pregnancy. Okay. So again, make sure that every child gets a rubella vaccine. These are some statistics that they like to show. So if a woman is infected during the first 2 months of pregnancy, there is a 90% chance that her child will be born with some sort of congenital rubella syndrome. So it's a really, really high risk. And the vaccines are relatively inexpensive, $2 to vaccinate a child against rubella. So they are still trying to worldwide vaccinate. The Americas were declared free of rubella in 2015. So again, the vaccine was licensed, you see, in the late 1960s, right after that outbreak. And the cases dropped significantly, total cases of rubella. The yellow line represents people over the age of 15 who developed rubella. And then in green, this line represents the number of children who were born with congenital rubella syndrome. And you see that the number basically goes down to 0 by the early 1980s. And that's, again, because of that robust vaccination program. If necessary, you can isolate the virus from the urine. If a patient has rubella, you can look for anti-rubella antibodies, but specifically IgM, right? Because IgM indicates an active infection, whereas IgG could be like the memory. So if you see high levels of IgM, that means that the patient probably has the active infection, that higher IgM to IgG ratio. Or you can do the reverse transcription PCR. There is no real treatment, but we do have a vaccine. It's a live attenuated vaccine. Okay. So any questions about rubella? Yes.
So, like you said, for you, like they tested to see if you had the antibodies.
Mm-hmm.
If they would have just given you the vaccine, would there have been like any sort of effect?
I mean, sometimes there's always a risk with the vaccine. So I was actually just planning to become pregnant, and so that's why I did all the screening. And so I was like, whatever, I would have just gone and got the vaccine anyway, but they were like, no, let's test you first. I'm like, whatever, if you want to bill my insurance, bill my insurance. But during pregnancy, vaccines can have a little bit more risk. Of course, not a greater risk than the infection itself, but they're like, well, let's check and make sure you're immune, and then, you can have the slight risk of the vaccine versus, the infection. So if you are planning to become pregnant, you can always talk to your doctor about that. Or, if you're undergoing fertility treatments, that'll be part of the screening as well, just to make sure that, when you do conceive, that you have as much as possible the immunity to rubella. Okay, any other questions about rubella? Okay, all right, like I said, we're gonna play Turlock General Hospital, but only one of you gets to be the patient today, not me. I am not the patient. So let me see here. I've got the list of everyone who's here. And I'm just it's got random numbers. So and you can see, I'll sort it so you guys can see. Let me zoom in so I'm not picking on anybody in particular. And then I'm gonna sort. So I did a random number generator, and then I sort by the numbers, column B, smallest to largest. Okay, Jose, you are the patient. So you get to be the patient. Donna, you're going to be the timer. Juan, you're the accountant. Angelina, you're the senior resident. And Simran, you are the attending physician. Okay, so let me go ahead. And see, I did it random. I was not picking on anybody. Okay, and you can use the same one you did for your exam. That's totally fine. Don't tell them what you've got. And then whenever you're ready, you can explain who you are and what kind of symptoms you're feeling, and then they will have 5 minutes to ask you questions. And there's so many diseases to choose from. It's like, how do you choose one that's like good, but
I can barely pick what I want to eat.
yeah, that's a conversation every day. What do you want for dinner? I don't know. What do you want for dinner? Oh, I don't know. What do you want for dinner? I don't mind. Whatever.
Thanks.
Whatever.
Yeah, whatever.
I helped you on Friday.
Yeah, I'm like, I just need somebody to tell me what to have for dinner.
That's,
All right, are you ready, Jose? Okay. I'm like, what's going on? Is it like a secret code? Y'all communicating via like...
Vallejo, like one of the most dangerous cities.
It was a little ghetto.
Which one is?
Vallejo?
Oh, yeah.
It was cool though. It was nice. We got to go on the boats that they have at the college.
We had a meeting for our game on Friday.
Oh, okay.
And we were like, where are you? And he was over there, and then after our meeting, I was on TikTok, and it was like, the most dangerous city is...
Oh, yeah, Vallejo. What, were you there for a president's thing or something? Yeah.
We were at Maritime.
Oh, okay.
Yeah, it's an interesting campus.
I'm on a boat. Part of it.
Well, the ship's gone because they're getting a new one. So yeah, it just recently got voted on, so they're all happy. But
All right, let's go ahead and get started. No pressure, Jose. Who are you and how are you feeling today? You can do the one you did for your exam, which I don't remember what it was, honestly, but I don't remember what everybody did. But everybody did one. If you don't remember what you did, yeah, that's the problem.
Yeah.
I feel that.
So I developed some flu-like symptoms. Recently went to go help my friend clean out a house. It's been abandoned for about a couple weeks. So up in, I guess, the woods.
And how old are you? You can be your own age, too. That's fine.
30.
Okay. Any other symptoms you want to tell them about, or you're not sure what else you need to share?
Not sure.
Okay, so then they will have now 5 minutes. I don't remember who was my timer, so I'm sorry. I put my... Oh, Donna? Okay, good. 5 minutes to ask you questions.
Do you have any body rashes?
No.
No rash? Okay. Or yes rash? Yeah? Okay. What other questions do y'all want to ask? It's a question to ask. And did he say yes or no? Oh, okay.
Did you find any rat feces or, like, yeah, like rat poop?
Yes.
Do you use gloves when helping with cleaning the house?
No. Did you use a mask though? No mask.
Is your rash like all over your body or
Localized.
Where's this match located?
How are we doing on time?
2 minutes.
2 minutes.
Yes.
Does your brain hurt? I mean, that.
Yeah.
Like, does your brain hurt? Or does like
Do you have a headache?
weird?
Yeah.
That's funny. Does your brain hurt? Yes, my brain does hurt.
Do you have a cough at all? Like with the flu-like symptoms, is that include a cough?
What? Yeah, just order pizza.
1 minute reverse twist?
Yeah, let's do pizza. I said that the first time.
If you don't have any more questions you want to ask and you do want to move on to the, discussion of what test you want, you can do that too. Does anybody have more questions you want to ask? Or are you ready to move on to the discussion?
Any diarrhea? Vomiting diarrhea? Shortness of breath?
30 seconds.
Get your last questions in.
I think it was
Time's up.
Okay, so 2 minutes to discuss what tests you may want to order.
Yeah. For. Yeah, should we test another one? For like any other viruses you guys think? Yeah.
What about radiolysis? Order that one?
I feel like radios would be So,
Yeah, it'd be more obvious, right?
What about Eliza?
Because he wouldn't be at the hospital until he got symptoms, and then by then the symptoms would be advanced.
well, maybe he already has the symptoms. It's too late.
Yeah. Rabies is like foaming at the mouth, right? And then he just ate it.
I mean, we always send a test for it.
It would be.
30 seconds.
It's not too expensive.
Are you the?
Yeah,
Who's writing down?
Dr. Van Mar, who's the attendant?
The attending is. Yep, and then Angelina, you're the senior resident. So, but Simran gets to make the call of what test you want to order.
Nucleic acid testing or birth transcriptase PCR?
For what? For what infection?
Oh, sorry, for hantavirus.
Hantavirus? Do you want to do any other tests? Or just that one?
Just that one.
Okay. All right, so you're running the test, reverse transcription PCR for hantavirus. Your patient comes back for the second visit. Do we have hantavirus, Jose? Oh, excellent. So he's happy that he's been diagnosed. What are you going to do for him? Now you have a minute to prescribe a treatment because you can't just tell him you have hantavirus, you're going to die. So,
If like, I think he's gonna die.
well, I mean, you can't say you have hantavirus, you're going to die, but is there an option here? So look at,
No real treatment for hantavirus, so probably just
Chamberlain, anti-inflammatory.
right?
Vitamins, something?
I would just say like, give him antibodies.
they're basically all saying you're going to die, Jose, by the way.
That's not necessarily true.
Hantavirus is one of the. Okay, I think that was your timer. So, doctor, what are you going to prescribe for your patient? Antivirals. Okay, cool. Are you satisfied with antivirals?
I'm happy with that.
All right. Cool. Yeah, well, I know you don't really have a choice, but all right, good job. He doesn't have to come back. He'll be all right. He'll be all right.
That's gonna cost us,
Yeah, it costs you a lot if he dies.
I mean, if we have nothing else to do,
Ah, that's
how's
true.
that our fault?
That's true. It's not your fault. It's not your fault. But sometimes, you know, people can sue anybody for anything. So sometimes people will try to sue you even if it's not your fault. All right, cool. So
Patients at work call all the time.
yeah, let's move on then to retroviruses. We're going to talk about a very specific retrovirus that is the most common one that causes human disease. So retroviruses are single-stranded, positive sense strand RNA viruses. They are enveloped, but they have a really weird type of replication. So, and we'll talk about that in just a second. So, the weird type of replication that retroviruses have is they encode an RNA-dependent DNA polymerase. So basically what they do is they bring their own enzyme with them, this RNA-dependent DNA polymerase that we call reverse transcriptase. And once they get inside the host cell, they use their genetic material as a template. So they use their RNA as a template to synthesize DNA. So this was the first time that scientists ever really saw and classified this violation of the central dogma. So remember, when you take a class like genetics, we talk about this idea that DNA can be replicated, DNA can be transcribed to RNA, RNA is translated to proteins, and that's it. Well, retroviruses say, actually, we can go from RNA back to DNA. And so they do that. Then the DNA integrates into the host chromosome. And the discovery of this was actually a Nobel Prize winning discovery. So it's a very unique mechanism of replication. We typically think of, and because it's med micro we're most interested in, something like HIV, which affects humans, but the first retrovirus that was isolated actually causes tumors in chickens. And as you might imagine, by integrating DNA into the host chromosome, there is a potential of inactivating like a tumor suppressor gene, or to accidentally turn on the overexpression of an oncogene. So they can cause cancer by integrating into the chromosome. Now, retroviruses tend to have limited host ranges. Generally, if, like, you're not going to get a retrovirus from the chicken, right? That's a chicken retrovirus. So it's pretty limited. Each virus is pretty limited in what type of host it can infect. And many members of the retroviruses are oncoviruses, right? They cause cancer. So the first human disease caused by a retrovirus was identified or isolated in 1981, and it's not HIV. It's called human T-cell lymphotrophic virus. And then what people started to notice in the US in the early 1980s was what they called the 4-H club of people who were dying of very weird opportunistic infections. Weird viral infections, weird fungal infections, bacterial infections that shouldn't kill people, toxoplasma, like some weird parasitic infections. So the 4-H club, homosexuals, hemophiliacs, heroin users, and Haitians. So those were the people that had just come from Haiti, people who were IV drug users, people who required blood transplants, and blood transfusions, and men who had sex with other men. Those were the populations where these infections were first showing up. And what they ended up calling it, they didn't know what it was, but they knew it was in these people, and they called it acquired immunodeficiency syndrome. These people had otherwise been healthy, and then all of a sudden they had no immune response anymore. They had no immune system. So it was an acquired immunodeficiency syndrome. Eventually, scientists were able to isolate and identify two very closely related viruses that cause this acquired immune deficiency syndrome. HIV-1, human immunodeficiency virus 1 and 2. HIV-1 and 2. They're very, very closely related. HIV-1 is way more common, but that is what it is. And a lot of analysis has gone into, where did this virus come from, or these viruses, where did they come from? And best evolutionary idea is that they came from consumption of contaminated monkeys or infected monkeys and other primates. There is a very closely related virus called simian immunodeficiency virus, SIV, and that it was able to mutate and jump into humans. In the early 20th century, so early 1900s, in Kinshasa, Democratic Republic of Congo. Okay, so the origin of the pandemic was very likely 1920s Kinshasa. And so the history of HIV is really interesting, and we'll get into that a little bit today and Wednesday, but that's where we think it came from. There are lots of other retroviruses. Throughout our evolutionary history, we have been infected by viruses. So has pretty much everybody else. And because these retroviruses have that kind of unique mechanism of integrating into the host chromosome, we have maintained a lot of these retroviruses within our genome. And so they call them endogenous retroviruses. And it's estimated that the remnants of these former viral infections can make up to about 8% of our whole genome. Are they active and actually cause infection? No, but they're there. And lots of animals have them. One of the main challenges, well, besides the immune response, but one of the other main challenges when scientists try to use things like pig organs to transplant into people is that when you put the pig organ in the person, the pig endogenous retroviruses become active, and so do the human ones, and they start attacking each other, and it's part of the rejection. So scientists have been using CRISPR to try to, one, remove all the immune markers from the pig so that our cells won't recognize them as foreign, and remove all of the endogenous retroviruses from the pig genome. So that in theory, you could have this basically neutral organ that the immune system wouldn't recognize as foreign. So those endogenous retroviruses can be a problem. Within the retroviruses, there are 3 families that cause human disease. We're going to talk mostly about the lentiviruses, HIV-1 and 2, but some of these other viruses can cause cancer in people, and there's one called human foamy virus, which I think is just a funny name. No known clinical disease, but it does make the cells look foamy, like they have bubbles in them that are vacuoles. It forms these vacuoles. So the oncoviruses are associated with causing cancer and having other neurological defects. The lentiviruses have a very slow onset of disease. They can cause neurological disorders and immune suppression. So HIV, sheep, goats, right? Monkeys and other primates that are not human. So when we classify them, we talk about the idea of what type of disease do they cause, what is their tissue tropism, what is their host range, morphology, how complex are they? The same things we use to classify every virus. Of the retroviruses, only those that fit in this oncovirinae group are the ones that transform cells and can cause cancer. But the lentiviruses, that's going to be the most common retrovirus we have in people that's associated with the slow disease progression and neurologic and immunosuppressive disease. They have to carry their own reverse transcriptase because they have to be able to turn their RNA into DNA. The DNA has to integrate into the host chromosome, then be transcribed, then be translated. So they go through a lot of extra steps. So they bring their own reverse transcriptase so that they can make the DNA from the RNA. And they bring their own enzyme called integrase to help them integrate their genome into our chromosome or into the host chromosome. They actually don't make very many proteins. The genome is not very complex. But again, with every virus we've talked about so far, bringing your own unique machinery or being dependent on your own unique machinery provides a really great drug target. So again, retroviruses, they bring their own reverse transcriptase, they turn the RNA into DNA, they use their integrase to integrate the DNA into the host chromosome, and then they transcribe their DNA back into RNA that can serve either as the genome or as a template for protein synthesis. Again, it seems like a really why would you go about doing this in such a complex way? But evolutionarily, they've been very successful. With HIV, what we see is that especially HIV-1 binds to a receptor called CCR5. So CCR5 is found mostly on CD4 positive T cells, so helper T cells, and some macrophages. And that's how the virus gets in. As the viral infection progresses, so later in the infection, they also start to use CXCR4, which is also on T cells. So they're really T cell tropic. They want to get into those helper T cells. What we see is that in some people of Northern European descent, there's a higher than average carriage rate of a mutation called CCR5 delta 32, where they're missing the last 32 bases of the gene. People who are homozygous for this mutation are resistant to HIV, at least most strains, because they don't make an appropriate CCR5, they don't make an appropriate receptor, so the virus can't get into the cell. So they are resistant to the infection. When we talked about in genetic biotechnology, we talked about CRISPR and how in China there was a scientist who did CRISPR on human embryos and made CRISPR babies, and there are CRISPR babies now that live in China. He was trying to make them resistant to HIV by making this mutation. It didn't work. I don't know if they're resistant to HIV, but they don't have the right mutation for sure. So that's how they get in. That's why they're really tissue tropic, right, to the immune system. One of the challenges with HIV, especially doing disease tracking, is that the reverse transcriptase is very error prone. So the genome is about 9,000 base pairs. It's very small. And every time it replicates, there are about 5 errors in that genome. And if we think about our DNA polymerase is basically like 1 in a billion errors get through. So it's like multitudes worse at proofreading than our polymerase is. And what this does is it allows new strains to form. It helps them evade the immune system once they get in, but it makes tracking very difficult because if you have 2 patients and you think one of them may have given HIV to the other, if you sequence both of their viruses, depending on how long ago the infection occurred, the viruses may look so different that you can't necessarily say one person gave it to the other. And so they have had some issues trying to track these things down. Like in Florida, I think back in the 90s, there was a dentist and a bunch of the patients became HIV positive. And he was trying to say it was like from contaminated like instruments. Yeah, it was not. It was from him. How he gave it to them, he never admitted, but Okay, doing that tracking gets difficult. And so what we see with HIV and with other lentiviruses that have this really long, slow progression of disease is that during the initial infection, and again, it could be sexually transmitted, it could be bloodborne, and that's about it. So you're not going to get it from hugging, you're not going to get it from kissing. It really is like sexual or bloodborne transmission. It gets into the immune cells, it travels throughout the body, it can go into the lymph nodes, and patients will experience what we call acute HIV syndrome, flu-like illness, because they have a really large viremia. After a while, the immune system can kind of get it in check and keep it tamped down. And this could be weeks, months, years, decades of the virus kind of just sitting there. And maybe slowly and steadily, the viral load is going higher, or the viremia is going higher. The number of T cells starts to decrease. And at some point, and I'll show you in a few slides, you have a patient who gets to a point where the viral titer is so high, the number of T cells, CD4 positive T cells, has dropped below a certain cutoff, and you have the presence of some sort of opportunistic infection. You now say that that patient has progressed from HIV to AIDS. So the majority of people who get HIV at some point will experience that drop in the CD4 positive T cells, the increase in the viral number, and the presence of these opportunistic infections. And that is most likely going to be what kills them. You have the reactivation of latent viruses. So they'll develop shingles. If they've been infected with herpes simplex 1 or 2, they'll develop cold sores. If they've been infected with HPV, they might develop warts again. They'll develop this Kaposi sarcoma, viral-related cancers. In some patients, though, it can cause disease in the central nervous system, and patients less commonly can experience AIDS-related dementia. Basically, the brain is destroyed by the infection. Okay. So how does HIV kill cells? One, it can form syncytia, so those giant multinucleated cells. You can also get CD8 positive T cells that will come in and go, you're infected, and kill them. And you can have what we call inflammatory apoptosis or pyroptosis, where the cell is trying to undergo apoptosis, but it doesn't do it correctly, because normally it should not be an inflammatory process. So it's trying to do it right, but it can't quite do it right, and so you'll have some extra tissue destruction. And that's thought to be induced by the circular viral DNA. So when the genome is reverse transcribed into DNA, that piece of DNA will temporarily be circular, and then it will go into the nucleus, relinearize, and be integrated into the chromosome. We don't usually have circular DNA, so that is something that tells the immune system something is wrong. And that can recruit other T cells to the site of infection. And so we'll pick up on Wednesday talking about what is specifically happening, looking at these numbers, and then talking about some of the statistics and the history of HIV in the US. Yes.
Why was the Haiti population like a big issue?
So that's a really good question. And so what it